Good morning/afternoon, everyone. I'm Dr. Asim Hussein, and I'm delighted to welcome you today. We'll be exploring infectious emergencies, specifically focusing on severe community-acquired pneumonia, or CAP. In this presentation, we'll cover the key aspects of recognizing, managing, and understanding this serious condition. So let's get started and dive into what makes CAP such a critical topic in infectious emergencies. Let's look at this case carefully. We have a 62-year-old man presenting with pneumonia, which already signals a need for close monitoring. His respiratory rate is 36 breaths per minute, indicating significant tachypnea, and his blood pressure is quite low at 86/50, suggesting possible shock. His PaO2 to FiO2 ratio is 140, which points to severe hypoxemia. Urea is elevated at 11 mmol per liter, and he's also confused, which could indicate altered mental status due to hypoperfusion or hypoxia. Now the question is, which feature alone requires ICU admission? When we think about ICU criteria, we focus on signs of severe illness, organ dysfunction, or instability. In this case, the low blood pressure combined with confusion points toward hemodynamic instability, a key marker for ICU need. Among the options, the most critical feature here is the septic shock requiring vasopressors. That's because vasopressor requirement directly indicates circulatory failure and the need for intensive support. While fever, high CRP, lobar consolidation, and a high CRB-65 score are important, they don't alone mandate ICU admission as clearly as shock requiring vasopressors does. So the most important point here is that septic shock, especially when vasopressors are needed, is a definitive criterion for ICU admission. It highlights how vital it is to recognize signs of organ failure early in pneumonia cases to ensure prompt, appropriate care. Alright, so the correct answer here is C, which is marked with a check. Now, the key point to understand is that ICU admission is necessary in certain cases of CAP, or community-acquired pneumonia. Specifically, when the patient has septic shock or respiratory failure that requires ventilation, they definitely need to be admitted to the ICU. This is true regardless of what the CRB-65 score might indicate. So, even if the scoring system suggests a lower risk, if the patient is in septic shock or needs ventilatory support, ICU care is essential. This highlights how clinical judgment and the severity of the patient's condition take precedence over scoring systems alone. Remember, the overall goal is to ensure that patients with severe presentations get the intensive care they need promptly. Let's take a closer look at this table, which helps us determine the severity of community-acquired pneumonia, or CAP, according to the ATS and IDSA guidelines. When we're assessing a patient, the key question is, does this patient have severe CAP? The first row indicates that if a patient has either 3 or more minor criteria, or just one major criterion, we classify the pneumonia as severe. This is a critical point because it guides us in making decisions about hospitalization and the intensity of treatment needed. Moving to the specific criteria, we see that fever plus leukocytosis is one of the minor criteria, meaning the patient has a fever and an elevated white blood cell count, which suggests a significant infection. Then there's the CRB-65 score, which is a widely used tool to assess pneumonia severity. A score of 2 or more indicates severe pneumonia, signaling the need for more aggressive management or hospitalization. Next, the presence of lobar pneumonia on a chest X-ray is another major criterion. If we see lobar consolidation, it points to a more severe infection. Finally, a positive sputum culture, confirming the presence of pathogenic bacteria, is also considered a major criterion. So, when evaluating a patient, we need to look at these specific signs and test results collectively. If they meet either multiple minor criteria or at least one major criterion, we're dealing with severe CAP. This helps us determine the appropriate level of care and ensures we're managing the patient as effectively as possible. Let's take a closer look at the correct answer, which is A. When we're diagnosing severe community-acquired pneumonia, or CAP, there are specific criteria to consider. Essentially, a patient is classified as having severe CAP if they meet one major criterion, such as shock or the need for mechanical ventilation. Alternatively, they can meet 3 or more minor criteria. These minor criteria include things like a respiratory rate of 30 or more per minute, a PaO2 to FiO2 ratio of 250 or less, signs of confusion, or low blood pressure. Recognizing these criteria is crucial because it guides us in determining the severity of the illness and deciding on the appropriate level of care. Keeping these points in mind helps us ensure we're providing the right treatment intensity for our patients. Now let's look at this scenario. A 70-year-old man with severe community-acquired pneumonia, or CAP, admitted to the ICU. Importantly, he has no risk factors for MRSA or Pseudomonas, which helps us narrow down our options. The question here is, what is the best initial empirical antibiotic regimen for him? We have several choices: amoxicillin alone, piperacillin tazobactam monotherapy, a combination of a beta-lactam plus a macrolide, a fluoroquinolone alone, or a combination of vancomycin plus meropenem. When selecting antibiotics for severe CAP without risk factors for resistant organisms, the goal is to cover the most common pathogens effectively. Typically, this includes Streptococcus pneumoniae, atypical bacteria like Mycoplasma or Chlamydophila, and sometimes Haemophilus. Choosing the right regimen means balancing coverage, safety, and avoiding unnecessary broad-spectrum antibiotics. For instance, monotherapy with a beta-lactam combined with a macrolide is often preferred because it covers both typical and atypical pathogens comprehensively. On the other hand, options like amoxicillin alone or fluoroquinolone monotherapy might be less appropriate in severe cases or when broad coverage is needed. And combining vancomycin with meropenem is generally reserved for cases with suspected resistant organisms or specific risk factors, which this patient doesn't have. So, in this context, the most appropriate choice would be a beta-lactam plus a macrolide, providing broad and effective coverage for severe CAP without overusing broad-spectrum agents. All right, let's look at the correct answer here, which is option C. The key point to understand is that for severe community-acquired pneumonia, especially in the ICU setting, the standard therapy usually involves a combination of antibiotics. Specifically, a beta-lactam like ceftriaxone, which targets the typical bacteria, paired with a macrolide such as azithromycin, which covers atypical pathogens. This combination is considered the go-to because it provides a broad coverage, addressing the most common bacteria that cause severe pneumonia. It's important to note that this approach is recommended when there's no evidence of resistant pathogens, making it a reliable initial choice. So, in summary, the main concept here is that this dual therapy, beta-lactam plus macrolide, is the standard ICU treatment for severe CAP without resistant pathogens, ensuring we cover all the common causative agents effectively. So, why do we add a macrolide in ICU-level CAP management? Well, let's go through the options here. Option A suggests it covers anaerobes only, but that's not quite right. Macrolides are more versatile than that. Option B says it reduces viral replication, which is not their primary role in bacterial pneumonia treatment. Option C is the correct answer. It covers atypical pathogens and also provides immunomodulatory benefits. This dual action is really important because atypical bacteria like Mycoplasma, Chlamydia, and Legionella often don't respond to beta-lactams alone. Plus, the immunomodulatory effects can help dampen excessive inflammation in severe pneumonia cases. Option D mentions preventing resistance, but adding a macrolide isn't primarily about resistance prevention. And E states it's only required if Legionella is suspected, but in ICU settings, we often add it empirically because of the broad coverage it provides. So overall, the key point is that adding a macrolide helps us target atypicals and modulate the immune response, both crucial in managing severe CAP effectively. All right, so the correct answer here is C, and I want to highlight why that's the case. Macrolides are particularly important in treating severe community-acquired pneumonia because they do two key things. First, they cover atypical pathogens, which are often responsible for pneumonia cases that don't respond to traditional antibiotics. Second, they provide anti-inflammatory effects, which can actually help reduce lung inflammation and improve patient outcomes. This dual action is especially beneficial in severe cases, where controlling inflammation and targeting atypical bacteria can make a real difference. So, understanding the role of macrolides in this context really ties into the overall theme of effective pneumonia management. Let's look at this clinical scenario. We have a patient with severe pneumonia who also presents with hyponatremia, diarrhea, confusion, and a recent stay in a hotel. These details are quite important because they point towards a specific type of pneumonia caused by a particular pathogen. Hyponatremia and diarrhea are common features in Legionella infections, especially in the context of recent travel or hotel stays. The confusion further supports the possibility of Legionella, as it can cause neurological symptoms in severe cases. Given this, our goal is to choose the most appropriate targeted therapy for this particular scenario. Now, let's consider the options. Amoxicillin and vancomycin are generally used for other bacterial pneumonias, but they don't cover Legionella effectively. Piperacillin tazobactam is broad-spectrum, but isn't the first choice for Legionella either. On the other hand, azithromycin and levofloxacin are well known for their activity against atypical pathogens like Legionella. They are often the go-to antibiotics for atypical pneumonia, especially in cases with travel history and symptoms suggestive of Legionella. Trimethoprim sulfamethoxazole is more commonly used for other infections like pneumocystis pneumonia, not Legionella. So, connecting all these points, the best targeted therapy here would be either azithromycin or levofloxacin, as they specifically target Legionella effectively. This highlights the importance of considering the clinical context, travel history, specific symptoms, and choosing antibiotics that cover atypical organisms when necessary. All right, let's look at the correct answer here, which is D. Legionella pneumonia is typically treated with either macrolides or fluoroquinolones. The key reason for this choice is that these antibiotics can achieve high intracellular penetration, which is crucial because Legionella bacteria tend to live inside the cells. By effectively reaching and working within the cells, these antibiotics are more capable of eradicating the infection. This point highlights the importance of selecting the right antibiotic class based on the pathogen's biology and how it behaves inside the body. It ties back to our overall theme of understanding targeted treatment strategies for specific infections. Now, let's discuss the key indications for ICU admission in patients with severe pneumonia. First, septic shock is a major reason. If a patient develops this, they require intensive monitoring and support. Next, if there's a need for mechanical ventilation, that clearly indicates the severity and the necessity for ICU care. Refractory hypoxemia, meaning low blood oxygen levels that don't respond to initial treatments, is another critical factor. Additionally, meeting the ATS or IDSA criteria for severe community-acquired pneumonia also guides us toward ICU admission. When we talk about severe CAP with an ICU focus, we're essentially emphasizing the importance of recognizing these specific clinical features early. They help us identify which patients truly need intensive care to improve outcomes. So, understanding these indications ensures timely intervention and optimal management for our most critically ill patients. When it comes to empirical antibiotics, a common starting point is a combination of a beta-lactam and a macrolide, especially if there's no concern for MRSA or Pseudomonas. This combo covers a broad range of typical pathogens and is often effective in less severe cases. However, if the patient has risk factors for MRSA or Pseudomonas, we need to escalate our coverage. That means adding vancomycin to target MRSA, or including an anti-pseudomonal agent if those bacteria are a concern. Now, when we're dealing with severe community-acquired pneumonia that requires ICU admission, our approach becomes more aggressive. In these cases, Broad-spectrum coverage is essential from the start to address potentially resistant or more aggressive pathogens. The key is to tailor our antibiotics based on the patient's risk factors and severity, ensuring we're covering all likely culprits. This approach helps improve outcomes and prevents complications, tying into our overall goal of effective, timely management of severe pneumonia. Let's go over some key ICU pearls to keep in mind. First, don't rely solely on the CURB-65 score when assessing severity. While it's a helpful tool, it shouldn't be the only factor guiding your decisions. Early administration of antibiotics is crucial because it has been shown to improve patient survival, especially in severe cases. Now, when considering Legionella as a possible cause of pneumonia, look out for certain clues. Hyponatremia, or low sodium levels, can be a hint. Also, gastrointestinal symptoms like diarrhea or abdominal pain, confusion, and a history of travel or hotel exposure should raise suspicion for Legionella. Finally, in cases of severe community-acquired pneumonia, especially those requiring ICU focus, keeping these considerations in mind can really influence outcomes. Recognizing these pearls helps ensure timely and effective management for our critically ill patients. Thank you so much for your attention today. I truly appreciate you taking the time to engage with this presentation. Remember, the key points we've discussed highlight the importance of understanding the core concepts and how they connect to our overall goals. I hope this has provided clarity and inspiration for your next steps. If you have any questions or want to explore further, please feel free to reach out. Thanks again, and I look forward to working with you all moving forward.